Timer has started and here is your question.
Okay, ma'am.
Yes. So if you have read
Yes.
and understood, kindly please tell me, considering a critical care scenario, how would you manage this patient with C-spine injury?
Okay, ma'am. I'll be managing this patient according to the ETLS. Okay, I'll be managing the patient according to the ETLS protocol. First,
Yes.
I'll basically assess the airway in which I'll be seeing that is there any foreign body or is there any accessory or muscle of respiration being used. Along with that, I'll be seeing if I can feel the patient breath on my chin, like listening, and in feeling, I'll be seeing for any kind of irregular breath movements. And if in case the patient airway is not being intact, I can do certain maneuver which are such as a chin lift and jaw thrust. And along with that, if the patient is not responding to that, we can go for oropharyngeal or nasopharyngeal
C
tubes. If the
patient has
patient
C-spine
having
injury. Yes. Patient has C-spine injury.
yes.
So
Yes, for this we'll be doing the chin lift and jaw thrust maneuver.
okay, next.
And along
What would
with
you
the
do?
airway management, yes, along with the airway management, if patient does not respond to these things, we might have to go for the intubation. And even if not on that, we might have to go for cricothyrotomy and tracheostomy. Along with that, we'll be managing the cervical spine with the help of the three things, such as basically a semi-rigid heart collar, along with that the sense bag and the taping and spine immobilization board. And later on going for the breathing, we'll be seeing the patient having enough oxygenation or not by assessing the patient having an equal bilateral movement of the chest, or along with that will be percussing. Sorry, yes. Along with that will be percussing. Is there any abnormal sound such as a hyperresonance or dull sounds, which may signify the hemo or pneumothorax? And is there an open wound on the thorax? And for this, we might have to do the needle decompression in the midclavicular line, or we might have to do the tube tracheostomy. And if the patient does not have all these things, but just oxygenation with the tight oxygen fitting face mask along with a 10-liter permanent would be enough. And in circulation, we'll basically first assessing the patient by seeing whether the blood pressure and the pulses are within the normal range or not. And for these, we basically seeing the central pulses, which is carotid and femoral. If there's a asymmetry in these, we might have to go for other interventions. And along with these, I'll be managing 2 large bore IV cannulas, sending the blood for cross match and other baselines. And for
All right.
disability, I'll be
Considering
seeing.
this critical care scenario, you did a primary survey. What do you understand by the term primary survey?
Ma'am, in primary survey, you basically try to rule out those potential injuries that can lead to the patient, which can threaten the patient's life within an hour or so.
If you'll do the X-ray of this patient, what would you find?
There would be right-sided multiple rib fractures along with the fracture of the foot, and there's a clavicle fracture as well.
Okay, can you help
And
me to read
as per
this?
yes, ma'am, there is a basically a comminuted fracture of the cervical spine 4 with anterior translation of that fracture segment, and there is a disruption in the spines, and there is, as its interior display, there might be the compression of the spinal cord as well.
Okay, considering it an RTA case, a patient has several rib fractures, multiple rib fractures. How would you
Yes, ma'am.
manage that? And has also right foot fracture. What would you decide which management to do first?
Ma'am, first the multiple rib fracture treatment has to be done. If it's just a multiple rib fractures, not any associated contusion or hemorrhagic fracture, pneumothorax, so just a good intercostal nerve block and good block, good anesthesia would be more than enough. In case of
What would be more
hemopneumothorax, might
important?
have to do the tracheostomy.
Yes, what would
Ma'am,
be
rib
more
fractures.
important, C-spine injury or rib fracture?
Oh, in comparing these two, there would be C-spine injury first.
Okay, how would you manage the pain in this patient? What
Ma'am,
would be your
if
approach to manage the pain? Yes.
ma'am, like we can start, if you're talking about in general, we
No,
can
for
do
this
give
patient,
certain
please.
IV medication, or ma'am, intercostal nerve block for the rib fractures,
Okay, can you tell me what you
and we can give
understand?
morphine as well.
Yes. Have you heard of the term WHO pain ladder?
So pain ladder, yes, ma'am, we can start with this as well. But in these patients, starting with like a paracetamol or NSAID would not be pretty much enough for these patients.
Do you think patient is in any kind of shock? If yes, then which class? How would you
Ma'am, yes, he is.
categorize it? Yes.
Ma'am, we can classify the shocks in. Are you talking about classification or
Yes,
grading?
class of hemorrhage. Yes, class of shock.
Okay,
Which
ma'am. Ma'am,
you
there are
said
4 classes.
yes. How would you know?
Ma'am, this patient might be in a class 3 or 4 as he's having an unstable vitals. In class 1 and 4, the vitals are comparatively stable. In class 1, basically we can divide both of them on the basis of the percentage and amount of volume of the blood that has been lost. In class 1, that would be less than 15%, and class 2 is 15 to 30%. In class 3, 30 to 40%. In class 4, greater than 40%. Talking about MF, that would be less than 750 in class 1 and 750 to 1500 in class 2. 1500 to 2 liters in class 3 and greater than 2 liters in class 4. Talking about the BP and pulse, the BP would be normal in class 1 and 2 and would be decreased in class 3 and 4. And talking about the blood pressures, pulse, it would be less than 100 in class 1 and greater than 100 in class 2, greater than 120 in class 3 and greater than 140 in class 4. Talking about the urinary output, in class 1, it would be around like 30 ml, in 2 would be around 20 to 30, then it would be around 10 to 5 in class 3, and 4 it would be negligible and might be patient anuric. And
What?
talking about the conscious level
Yes.
of the patient,
Yes.
patient might, in class 1, patient would be mild, slightly anxious. In 2, there'd be mildly anxious. In 3, patient would be confused, and along with that, would patient be anxious. In 4, patient might be lethargic to in the coma state.
All right. Good. Can you already said that patient is in a state of shock? How would you manage that?
Ma'am, by make sure that the patient had 2 large bore IV cannula has been placed, patient starting with the fluid resuscitation, giving a bolus of a 1 liter isotonic crystalloid, and we reassess the patient vitals by making sure the patient having enough resuscitation. If the patient blood pressure and pulses start coming to within the normal range or not, that will justify that the patient is responding to the resuscitation that we are giving to him.
What else would you rule out before you will go ahead with 2 cannulas and all this rehabilitation that you have mentioned? What is the most important thing that you'll rule out first?
Ma'am, we have already discussed the airway and cervical spinal
Yes,
injury,
but you'll
and
rule out if patient is bleeding actively from any source.
yes,
So you have to
yes,
stop the
if
bleeding.
yes, ma'am. If there would be an obvious wound, then instead of ABC, that would be starting with the C, controlling of the bleeding by applying a lot of pressure over there.
All right. Can you please tell me how would you make sure the fluid challenge that you're giving or the fluid rehabilitation that you're giving to the patient is in fact responding to it?
Is respond, ma'am. Basically, if you're going to resuscitate the patient, giving the patient the fluid, if the BP start getting raised, coming within the normal range, or maybe a bit higher than it was before, and the pulse
Yes.
getting a decrease, that mean along with the urinary output, which will be much important thing, and the capillary refill, like by seeing the patient's skin, they all will tell you about that the patient having enough resuscitation or responding to it or not.
How much capillary refill should be normally?
Ma'am, it should be in 2 seconds.
Good. Okay, good. Thank you.
Thank you,
All right.
ma'am.
Yes, give feedback, please, to Dr.
Ma'am, I want to ask one thing. Can
Yes,
I?
please. Yes, please.
Ma'am, ma'am, basically, I studied the compression syndromes. So, can we ask the compression syndromes in cervical spine injury, like a tear cord compression, Brownlee cord, and central cord compression syndromes?
These are the complications that lead occur as a result of C-spine injury. Of course, you
Okay,
should know
ma'am.
if they are asked. But yes, can anyone, if anyone has listened to presentation carefully, would want to give feedback?
Dr. Shwag and Suman, please.
Yeah, one thing
Yes,
I would like to add that you have
yes,
to be careful in cervical spine injury. You have to
yes.
mention that before
Going
mentioning
again
the
to
jaw
breathing.
thrust
Yes,
or
yes,
jaw thrust, chin lift, or any maneuver around the neck. You have to mention that I will be careful about the cervical
yes,
spine suspected or obvious cervical spine injury.
yes.
And there is one term given in the ATLS book that you have to maintain the cervical spine by a inline traction. That is,
Very good.
another person will hold the head and cervical spine in a line without moving it too much, and then you can do the jaw thrust or chin lift or even intubation. Because if the airway is blocked, that is also serious. You have to confirm that it is not blocked, or if it is blocked, you have to do the intubation or opening anyhow. So you have to do that, but you have to protect the cervical spine also.
Yes,
Sir, so what we'll be saying that first doing the inline immobilization of the spine, then followed by the
Yes.
jaw thrust and chin lift maneuver.
No,
Is
inline
it?
no,
mobilization will be done by another person.
another
The
person.
Okay.
person who
Read
will
here,
do the, yeah, yeah,
read
that
here.
will always keep the spine in a line. It will not allow
Okay,
to
okay.
move it too much.
Okay, sir.
Yeah.
Thank
So
you.
this is also written by Dr. Ishfaq. Yes, would you want to say it, Dr. Ishfaq, or it's contraindicated if you'll just do it with C-spine injury, jaw thrust and
Usually
all?
we avoid it unless it is
Yes,
necessary.
yes.
Ma'am, is
So this part of your management was not correct by default. Okay, so you have to read more and you have to understand the concepts. Like you have to clear your conception when you're explaining
Um,
management. You have to be. Yes. Anyone else want to add anything? Someone said, "Oh,
ma'am,
yes,
I was just asking if a cervical spine, instead of the inline immobilization, like Dr. Suman has said, with the help of another person, couldn't we just go for the hard collar, cervical hard collar, and then immobilize it like that?
right away
Like I'm
Uh,
asking.
without confirming."
yeah, yeah, sir.
Okay, you can.
Philadelphia collar will be applied, but if you have to put the
Mm-hmm.
you have to do the jaw thrust or chin
No,
lift,
in that case,
it
no.
will,
But if we suspect there is a cervical spine injury, in
yeah,
that case, we
it
won't
will
do
be
the jaw
there.
thrust, right? Chin lift and jaw thrust
I
maneuver would
another
Usually
not be
we,
person.
done, right?
yeah, usually we don't do, because,
Okay.
but how, if there is a airway blockage, then you have to
All
do
right.
something. In that
All
case,
right.
you
All
have to
right.
remove this Philadelphia collar, because it presses over the jaw and it closes the mouth.
Uh huh.
Yeah,
Okay.
Philadelphia
Okay.
collar is like that. It presses over the
Mm-hmm.
base of the mandible. So to do any maneuver, you
Oh.
have to remove this collar.
Dr. Ulfat, you'll do those
Okay.
maneuvers only when there is obstruction to the airway. If there is
All right,
only
Yes.
ma'am.
C-spine injury and there is no
Mm-hmm.
obstruction, then you'll just have the collar. You'll not do the maneuvers. Dr. Ishfaq wants to
Maneuvers.
add anything. Yes, please.
Okay. Thank you so much, ma'am. Thank you, Dr. Suman.
Wait,
Thank
Dr.
you.
Ishfaq wants to add anything. Yes, please.
Yes, yes, ma'am.
Yes, ma'am.
Recently, according to the recent guidelines of the
Yes,
ATLS, it has been said that it is impossible to fully immobilize the cervical spine. That the concept has been changed from immobilization to restricted movement. There will be
yes,
always some movement, but it can't be always like immobilized. So better is to avoid the
Yes.
both jaw thrust and chin lift. If there is confirmed injury, better is to avoid not to do these things.
yes,
And as Dr. Suman has said, inline immobilization with the help of two persons.
yes.
So better to avoid these things. Uh,
And
this is
Dr.
the
Okay.
Sridat is saying something. What do you mean by triple immobilization?
Basically, what they've said in the ATLS guidelines as well is when there is suspected C-spine injury, always start off with saying they'll be doing triple immobilization. I will stabilize the C-spine with the help of sandbags, tapes, and collar. This is
Yes,
triple immobilization. We can stabilize it when there is a suspected C-spine injury, unless there is, like Dr. Shraga said as well, unless there is severe or serious airway compromise, we'll try and do
Yes.
suctioning first. And if we can get an airway, there are obviously there is oropharyngeal, nasopharyngeal, and surgical airway methods as well. Depending upon if there is serious compromise, then the maneuvers are tried of jaw thrust and
Yes.
then chin lift.
Yes.
But then again, most with suctioning, if we can get a good decent airway, when we will place the patient on 15-liter oxygen, non-rebreather mask, and then continue on to breathing.
Yes.
Yes,
Yes.
So
right.
like in case
And Dr. Murali, and one thing I want to add, currently the sandbag is not used. It has been replaced by the semi-rigid collar. We have to use the semi-rigid collar. The
So
concept
in the
of
teaching over here, they say triple immobilization with. Sorry to stop you, but the teachings over here they say triple immobilization with all three. They have asked us to mention that. Just informing.
okay, so I was saying according to the ATLS 10,
Yeah.
it is yes, that's what I'm saying.
Yes.
Actually, I will tell you that nowadays this hardboard comes with a two hard. It is not like sandbag, but there is two block on which is kept on both side of the head, and
Yeah.
it is bound by the strip. So the head
Yeah.
becomes completely immobilized. Nowadays this
Mm.
comes. Although we also call this the sandbag, but it is not actually the sandbag.
Yeah,
Yeah.
it's basically two blocks on either sides of the head, and then we just
Yes,
strap it
yes,
together with
yes.
the help
What
of
we
two.
use here
Hmm.
and any
Yeah.
other hospital.
Yeah.
Can I add something if you guys don't
Yes,
mind?
please. Yes,
Just
please.
one point. You mentioned about sandbags, collar, and blocks. Whatever you use, the whole point is that you don't need to move the neck. So as far
Yes.
as in the exam you say, I'm gonna stabilize the neck. Either way, you say triple line inline immobilization or with the collars or with the tape or whatever, it's right. The whole point is that you are safe and you're not moving the neck.
But you should have a clear concept of what you are moving.
It
If
depends.
like
Every trust is a different guideline. So if you have a collar available in hand and you put a collar on, your neck is safe. If you don't have a collar available, you can use sandbags. If you have sandbags, you use blocks, whatever. Just for your own learning from the exam, if you're making a question, if you're making an answer, how to answer this question, just say, I'm gonna do inline immobilization of a C spine before you move on to airway.
that you will do with the help of others. So you should, like what we are doing here, we're discussing, so each and every one of you should have clear concept that one person is not managing the C spine injury. You need help of others as well. And why they are discussing sandbags or blocks, because you should, it's for the sake of knowledge that you should know sandbags were before used, now they are having they're being replaced by the blocks. So, and they are new guidelines, so that's why. Yeah.
You can use Miami J collar, you can use hard collar, you can use anything. And once the collar is on, in the collar there is a window just at the front of your neck. So you can, if needed, you can do crack through it as well.
Yes. Yes. Yes, Dr.
so
Tashaba,
like
you were asking something. Yes.
yes, ma'am. I'm like a bit confused. Like if it already been said in the scenario that the patient has a cervical injury, so we won't be doing any maneuver altogether. Like we'll be just starting with the suctioning and removal of the foreign body, later on going the oropharyngeal way. This is what I could have deciphered. Like in case you have been given clear cut notion that the patient has a cervical injury, you won't do those two maneuvers, right?
But still, in your first survey, you have to rule it out. I said, okay, there is, but
Okay.
you'll still rule out and then you'll do the management. Okay, and once
Okay.
there is, so you won't be doing the jaw thrust and all those maneuvers until unless you say there is obstruction to the airway. And what Dr.
Okay.
Ishfaq and Dr. Shir said, that if there is severe obstruction, okay, yes, they want to say something. Yes, please.
Ma'am, I just want to add that
Yes.
the scenario is different, but obviously, when you're getting a call, you always say with the level of the mechanism of injury. So they say there is suspected C-spine injury. You obviously
Yes.
cannot diagnose that on the field.
No.
So whenever they mention that there is a C-spine injury, suspected C-spine injury, the first thing you just say is triple immobilize, or I'll just catch the spine and then stabilize it first, then go on to airway, then breathing, then circulation, like that.
Sir, as you shared in the group, it says like you can do the jaw lift or jaw thrust with chin lift in the patient with these cervical spine injury.
I wouldn't actually. I would stabilize the C-spine first. I wouldn't actually, unless, like I said, it's completely compromised and I'm not able to get any
Okay.
other airway. Then I don't know if the guidelines have changed or not.
If you're just
Okay.
asking for your knowledge, you can do jaw thrust and chin lift if that's your last
Yes.
resort or you don't have anything else
That's the
available.
last. Yeah,
Yes, and
there's no
also
left.
you need someone to keep the neck in line, or at least the neck is in collar.
Okay.
Yeah,
Thank you.
good. Any more questions? Or his spines are managed simultaneously? Yes. You can't just sit and wait. Yes.
Mm.
Yeah, good. All right, very good. Started the timer and here is the question. Right, if you have read and understood, kindly begin your history taking.
Hello.
Hello.
Hi, my name is Vajji. I'm one of the exam candidates. Can I confirm
Okay.
your name and date of birth, please?
My name is David and I'm 48 years old. 43 years old. Sorry.
Hi, Mr. David. Nice to meet you.
Nice to meet you, doctor.
I have been asked to to ask you a few questions regarding the pain in your legs. Is that all right with you?
Okay, that's all right. You can go ahead.
So I understand you have some pain in your both legs. Tell me more about it. When did the first time you notice this pain?
Doctor, I have been experiencing this pain from last couple of weeks, more than 5, 6 weeks. From last 1 week, it's increasing in severity. I can't hardly walk more than 50 meters.
I'm sorry about that. So it's from
Mhm.
last 6 weeks. Where exactly?
Yeah,
Sorry.
around 6, 7 weeks. Yeah.
And where exactly do you feel the pain?
It's there my legs, mostly the lower part of the legs, but at times my lower back and my thighs get involved as well.
Okay, so you feel pain more in your calf. Do you think this pain comes down your back, or is it more like starts in your feet and comes up?
No, it doesn't go like it doesn't come from upwards downwards. I feel it like it's coming from from my feet upwards, yeah, more on the lower side of my legs
Right, right,
than the other upper side. Yes.
right. And
Hmm.
do you think the pain gets worse when you're walking or when you're sitting down?
Yes, doctor, absolutely. When I walk too much, it's getting worse, and then I have to take the rest. After that, I get some relief.
Okay. And
Hmm.
you said it's like you walk for 50 minutes and then you sit down. This distance,
Yes.
has it gone?
Meters.
Yeah, right, right. Maximum 50 meters I can walk at a time. Then I have to take a rest for a couple of minutes. Then I can walk again. Yes.
In the last 6 weeks, this distance, has it gone worse or is exactly the same?
Like I told you before, it's getting worse day by day.
Okay. How much you can walk
Hmm.
now?
Like I told you, not more than 50 meters.
Okay.
Hmm.
Um, Tell me more about the pain. Is it like a sharp pain or is it like dull, constant ache?
It's dull. It's there all the time. Dull aching pain.
Do you feel any chest pain with it?
No, no, I didn't feel any chest pain.
Any shortness of breath?
No, my breath is fine.
Okay. And anything which you think makes it better?
Yes, by taking rest and taking pills at some time, but rest is the most important, relieving factor for me.
Right. And anything you think makes this pain go worse?
Yeah, apart from walking, I told you that before, and whenever I feel cold and the environment is cold around me, and taking cold showers, it makes it worse that time.
Okay.
I,
Have you
I
noticed
hardly bear it. Hmm.
have you noticed this pain getting worse at night time in particular?
No, sorry, doctor, I haven't observed that thing.
Okay. Have you noticed that if you hang your leg outside the bed, the pain gets
Mhm.
worse or pain gets better?
I haven't observed that thing as well. By taking rest, it is getting better, and the only thing which makes it worse is the walking and the cold things around me.
Okay, that's fine.
Mhm.
If I ask you to rank this pain from 1 to 10, 10 being the highest, how on your worst day, how worse is the pain?
On my worst days, maximum around you can say like 6, 5 or 6.
Okay. Have you noticed any
Mhm.
discoloration of your legs?
I have recently observed that I have lost, my hairs. I have lost the hairs on the lower side of the legs, and the skin is bit shiny. I feel that way. Maybe some changes recently. You can tell me more about that later.
Have you noticed any lumps and bumps in your legs? Any breakdown of
No, I haven't. No, no, no.
any obvious veins in your legs?
No, doctor.
Any breakdown of skin? Sorry, I don't know if you said answer this question before or not.
No, no, no. No breakdown. As of yet, there is no breakdown.
Okay. Any pins and
Mm-hmm.
needles in the feet?
Couple of times, not oftenly, but occasionally.
Okay. Um,
Mhm.
any other medical problems, sir?
I have this what we call the hypertension. I'm taking some pill for that. It's under control. My GP told me that it's under control. You continue with this pill.
Okay. Any other condition?
No,
Apart from medication for hypertension, any other pill you're taking?
no, doctor. I'm not taking any pill.
Any allergies?
No, as I can remember.
No. Good. And any surgeries you underwent in the past?
No,
And have you ever been told that you have a funny heartbeat?
no, I haven't been told that.
No. Okay. Anyone in the family with the similar problems or with a history of heart attacks or stroke?
No, 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 doctor. Nothing like that. My family was, fit and well.
What do you do for your living, sir?
I'm a teacher by occupation.
Okay. And who is
Mhm.
at home with you?
I live with my wife and two young children.
Okay. You walk with a
Mm.
stick, without a stick.
No, normally I am fit and well. I was doing from before 6 weeks. I was playing football with my kids and all these things. But from these 6 weeks, this problem is getting worse, and I came to know I should see you.
And how do you smoke?
Yes, doctor, I smoke a lot. I must say, from last 25 years, I'm smoking almost 10 to 12 sticks per day.
Okay. And do you drink?
Occasionally,
Like how much roughly is your alcohol intake?
I 5 6 units per month, not more than that.
Okay. Is there
Mhm.
anything else you want to ask? You want to tell me which I missed?
Yeah, no, I told you everything. You asked me everything. I think I've told you enough.
Okay.
Hmm.
Um, what are you expecting from this consultation today? What do you think is going on?
I want you to fix this thing for me. I want to, doing my things normally what I was used to do before this thing, and I want to play again with my kids and move around. This pain is really, hampering my daily activities, making me miserable. Please do something for me.
Yeah, I completely understand, Mr. David. Thank you for your time. I will get back to you as soon as I can. Okay.
Okay, thank you, doctor.
Thank you.
Please.
Okay, can you summarize your case?
I've been asked to see Mr. take a history from Mr. David, who is a 43 years old man having trouble with his with vascular claudication from last 6 weeks. He has a distance of around 50 meters. And after that, the pain in his bilateral calves make him sit down, which relieves the pain. He reports some back pain, but it does not radiate down. In fact, his pain is more ascending and corrected and starts in his feet and comes up. He
So what
reports
is your differential diagnosis?
my top differential would be peripheral vascular disease. The pain can be related with the spinal stenosis or critical, chronic limb ischemia or acute on critical limb.
How would you differentiate between spinal stenosis and peripheral vascular disease?
Firstly, the pain pattern. Spinal stenosis will have back pain coming down the legs, but that can not always be the case. The peripheral vascular disease pain is more localized in the calves. Secondly, the spinal claudication relieves the pain with the patient in kyphotic posture or when they are moving up the hill. That's not the case in the peripheral vascular disease. And Mr. David has the few risk factors for vascular history, for vascular disease.
Okay, what should be the management of this patient?
After the history, I would like to examine this patient and send some baseline investigations, starting from full blood count, UNEs, clotting factors, group and say then hemophilia profile, and bleeding times and all those things. And after that, I would like to arrange ultrasound Doppler of his arterial system of the lower legs, and I believe he will need a CT angio as well.
Yes. Then what should be the treatment for
I will
this
start
patient?
with the conservative treatment first,
Yes.
which will involve smoking cessation,
Yes.
exercise, antihypertensive, and antistatins. And he's not diabetic, but we'll just keep an eye on his diabetes as well. If with the 6 weeks trial it does not improve, then we'll move on to the medical management, which will involve angio, CT angio, and he might need a he might need an angioplasty and long life anticoag.
Yes. Good. Okay. It was excellent. You covered everything. But the problem is that you took 1 minute and 30 seconds extra.
But I'm improving then.
Yes. Yes. Yes.
The 60
You are
seconds.
improving. You are getting there. So hopefully with next 2-3 practice, you'll get there. Because today it's less than 2 minutes. So, okay. Yes.
I forgot trauma history
Good.
though. I just remember it now. I forgot to ask him trauma history.
Yes, but maybe in this one, it's not that much important. Why?
It's bilateral.
Yeah, patient already told you that there are factors because of which you can rule it out, associated with cold and relieved by rest, and so you can more or less you can rule it out that it's not associated with trauma. But yeah, it was good.
Dr.
Anyone else
Uziha,
want to give? Yes.
I think you, yes, ma'am. I think she should have asked me about this walking uphills to rule
Yeah.
out the second difference, like
Yes.
spinal canal stenosis, and that should have been asked.
Yes.
The rest,
And
she asked
to
me
rule out
everything. That's
sciatica, what
given.
question she should have asked?
Sciatica, she already told me like if it is going from back
Yes,
to.
she asked, but the history of
Yeah,
lower back pain, if you ever experienced it before,
ready.
yeah.
He
Yeah.
told me already he had a back pain. That's why I didn't ask him.
Yeah. All right. Okay. Yeah. But then she did ask you because spinal claudication is associated with limb numbness. So this is one associated thing. But yes, walking uphill, yes, when she
Yes.
asked you, how does it get relieved or how does it aggravate? So she kind of covered it there. That's why I didn't point it out.
Yes, ma'am.
Because if patient
Right.
is experiencing it pain relief by walking uphill, patient will say it itself.
Right.
Yeah, good. But still, yeah, you pointed out, okay, good. But then I thought she has covered it in the question when she asked you what relieves it or what makes it worse. So that was covered. But then I asked her in the questions. So just to make sure if she knows what she's talking about. All
Right.
right, good. Yes. Someone else wanted to say something. Yes. Yes, Dr. Osaf. It's mostly unilateral cardiac vena. Yes. I thought Dr. Ulfat wanted to say something.
Stenosis can be
Started the
Right, ma'am.
timer, and here is the question. Good. If you have read and understood, kindly begin history taking.
Okay. I will wash my hands. I will provide this DP if required. Hello, my name is Dr. Ishfaq. I am one of the doctors working here. May I confirm your name and age, please?
My name is Mr. James, 57 years old.
Good.
Nice to nice to meet you, Mr. James. Actually, today I have been asked to ask you a few questions regarding your condition. Will that be okay for you?
That's fine, doctor.
Okay, great. So, can you please tell me how can I help you today?
So, doctor, I've been having this abdominal pain for the past 3 months now.
Okay.
Yes, that's why I'm here today. And
Okay.
it's
I'm
getting worse. Yeah.
really sorry to hear that out. Can you please tell me more about your this pain? When did it exactly started?
So, it started about 3 months ago, to be exact.
Okay, right. Can you please point out the site of pain with your finger?
Yes, doctor, it's around my lower side of my tummy.
Okay, I got you. Right. So, can you please tell me, like, did it started all of a sudden, or did it started gradually?
It was a gradual pain. It
Okay.
was gradual. Mm.
Okay. Can you describe the pain for me? How it is like dull, sharp, like knife cutting pain, burning?
It was sharp pain.
Okay, very sorry to hear that out. So, if you have to, rate the pain from 1 to 10, 10 being the most unimaginable and most worst pain you have ever felt, how do you rate it?
Now it's almost 10 for the past few
Some,
weeks.
oh man, I'm really sorry to
Yes.
hear that. Do you want me to give some analysis because I'm presently in pain?
Yes, doctor. I can cope with that.
Okay,
I
okay,
appreciate that.
okay. Thank you. So, do you think there is anything which makes it pain worse, or it is making it better?
The pain, it's always there. So then nothing makes it better. It's always there.
Okay. Okay, right. Do you think it's going anywhere apart from your, lower side of the tummy, upwards, backwards, downwards?
No, doctor. It's in the lower side around my left side. That's what
Okay.
it is. Yeah.
Have you observed, right? Have you observed any fevers, in the last couple of days or couple of
Yes,
weeks?
doctor. Yes, I've been having high fever, about
Okay.
38, 39 at times. Yes.
Okay. So the fever come anytime, or there is
Yes.
a particular time of the day the fever doesn't? Anytime.
No, I'm always febrile.
Okay. Okay.
Always have
Really
fever.
sorry to hear that out. Okay.
Mm.
So, do you think have you observed any lump in your tummy recently?
Yes, I've noticed this mass. It's like there's something that is always jumping.
Okay. Any
Mm.
how's your how's your appetite?
Oh, I've lost a bit of appetite, but not much.
Okay. What about your weight? Have you lost any unintentional weight you don't want to lose?
No, I've not
You haven't.
lost weight. No.
Okay, great. So, can you please tell me about your your water works and your bowel habits? Are they normal? Or you see any change in them?
Yes. Yes. No changes. No changes, doctor.
Okay. Any muscle pain? Any shortness of breath? Any palpitations? Any chest pain?
No, doctor.
Okay. Have you been to any other country recently?
Have I been what?
Have you have you been to any
Overseas.
other country overseas? Have you
No.
Is,
I've not traveled recently.
okay, right. So, is there anyone else in your family who has experienced the same in the past?
No, I'm the first person.
Okay,
No
right.
history.
So, okay, right. So, do you have any other condition you see your GP for?
Um, Not really. Since I started having this abdominal pain, that's the only reason I've been seeing him. But I've not known what's wrong with me. But I've
Okay,
been having
right.
fever, all this. Yes.
Okay, right. Any surgeries in the past?
No history of any surgery.
Okay. Are taking any medications?
Only antihypertensives. I'm a non-hypertensive patient.
Okay. Can you remember the name and dose if you remember?
Mm, no, really, doctor. But I know
It,
it's an
it's
antihypertensive.
it's okay. It's okay. Do you have any allergies you want to tell me?
No other history.
Okay, right. So before proceeding, can you please tell me, do you have any idea what might be causing this, this bumping, this pulsatile mass in your tummy?
Doctor, I thought it has maybe it has a relationship with my pressure, my
Uh-huh.
blood pressure, but I'm
Okay.
not really sure. Yes.
Oh,
But,
right. Okay. So what? So what's your biggest concern?
so my concern is the pain. It's really painful, and then I've been having fever as
Okay.
well. So
I can understand
yes.
that. I understand that. So what are you hoping us to do for you today?
To know what it is, and then to take care of my pain, especially the pain.
Right, definitely. So is there anything else you want me to tell that I have missed that you want to tell from your side?
No, doctor. I think you have asked me enough.
Right. Okay. Thank you very much for your time. Thank you very much. Okay.
My pleasure, doctor.
Can you?
Okay, I would
Yes.
like to present my case. Today I have taken history from a 57-year-old male who came to the ER with the complaints of lower abdominal pain. The pain started from last 3 months. It is getting worse by worse. It's present in the lower side of the tummy. It's not ready to any side. And the patient scaled it 10 from 1 to 10, and it's not getting relieved by anything. Patient is also experienced fevers from last couple of weeks. Its fevers are present throughout the day. Patient has no change in the appetite, no unintentional weight loss, no change in the bowel or bladder habitus, no the joint pain, muscle pains. So
So, what should be your
he has
differential
observed.
diagnosis?
So my differential diagnosis will be the abdominal aortic aneurysm.
Okay, good. What type of abdominal aortic aneurysm this patient might have?
This it can be the true aneurysm or it can be the false aneurysm.
Is there any other way you can classify abdominal aneurysm?
Yes, we can depending upon the location. Firstly, anatomy. If
All
it is
right, good. Any other way?
suprarenal or infrarenal.
Yes,
This is infrarenal or suprarenal. This
yes,
is abdominal aortic aneurysm or auric aortic aneurysm, or this is true aneurysm or false aneurysm,
yes.
or
And
this is uh, this is secular aneurysm or uh, secular aneurysm or what we call
okay,
the
we'll discuss this. How should this patient be managed?
okay. After taking the history, I would like to do the full neurovascular exam, full cardiovascular examination in this patient and peripheral vascular
Yes,
examination in this patient. And after that, I would like to do some investigations like full blood count, urea electrolytes, LFTs, markers of the inflammation, look for the investigations for to check for the syphilis if patient is having, that might be the cause of aneurysm as well. And after that, I would like to have some investigations like the basic ECG, the X-ray chest, and the aerography in this patient. After that, I would like to discuss my case with my consultant in an MDT with my radiologist and the cardiovascular surgeon, anesthetist, and the nurse, specialist nurse. After that, we can manage the patient according to the size of the aneurysm and the urgency needed. If the patient is present acutely and with a rupture of the aneurysm, we have to take him to the theater immediately and resuscitate the patient and to take him to the theater at the same time. And if the patient is having aneurysm of less than 5 centimeter, we can manage it conservatively by having serial ultrasound every 6 monthly. If it
This
is greater
patient
than
was
5
also having fever, so would you or would you not uh, prescribe antibiotics for the patient?
Yes, ma'am. I'm coming to that. After that, as this patient is complaining of fever, I would put him on the broad spectrum antibiotics covering the both gram positive, gram negative, anaerobic and aerobic cover.
Yes.
And after patient is settled, the fever is gone and the infection is controlled, we can plan him for the surgery. The surgery we can divide the minimally invasive surgery and the open surgery. In endoscopic surgery, we would like to put a stent through the femoral root, or we can, if that's not possible, we can go for the open surgery and put this endoscopic stent and stitch it.
Okay, good.
Yes, ma'am.
Right. Are they saying anything?
I have to say
Yes.
something.
Yes.
Dr. Isfaq has in the stem itself, it says that it is a pseudoaneurysm. Ma'am, can you show me the question?
Yes.
Yes, doctor, but because I have to make a
So,
diagnosis, undiagnosis, I can't say it is a pseudoaneurysm or
Yes.
it is a false, sorry, true aneurysm. If I have to make a provisional
yeah,
diagnosis, I can't say it is either this and that. That's why I didn't. Otherwise, I read it.
okay.
It can be pseudoaneurysm can be due to due to
So
strep trauma.
how will you manage? No, no. My question is, how will you
Okay,
manage if it is a pseudoaneurysm? That is my question
okay,
actually.
Yes. This is also
okay.
my. This
See,
was also my question. Yes, please.
Yeah, and it is also infected. Suppose because he has
Yes,
a
it is
fever, so it is.
infected.
I'm supposing it is infected. So now,
Yes.
how will you manage?
This is one
so
article I will share later on, but then please, yes, discuss.
so as ma'am, this is infected aneurysm. Firstly, we have
Yes.
to give the patient the broad spectrum antibiotics, control the source of infection. And after that, depending upon the size of the aneurysm and the site of the aneurysm and the patient's clinical condition, if it is less than less than 5 centimeter, the management is same. We have to serially observe it, and if it's very thinned out, we have to excise the aneurysm, or we can put a stent. Mostly, we put a stent in the aneurysm after
Yes.
only after the infection is controlled. And if it is true aneurysm, then the things are different. Dr. Suman?
Yes, please.
Yes, like because it is a pseudoaneurysm, so cannot
Yes.
we ligate it? Just ligate it.
If
I
it is
don't know. I
involving
have
the
to be.
abdominal aorta, we
No,
can't ligate it.
yes.
That's
Okay.
my point.
If it is involving the okay, okay,
Yeah,
okay.
can't ligate it.
Yes. Management would have been different if a vessel involved would have been different. But this is the
Yeah.
largest vessel which is involved.
Yes, ma'am.
And they are doing debridement with or without
But
revascularization via endovascular or open procedure.
that is not for aorta, ma'am. That is for I
No,
think different.
that's
Please.
sorry.
This is a
Yeah.
small.
And these are the differentials that they thought they will consider. It's good. You should like keep this in your mind. Could be atherosclerotic
Cellulitis.
aortic aneurysm, or cellulitis is number one, because cellulitis can cause fever as well. Then pyelonephritis, because one mass in this loin region can be because of renal. So inflammatory aortitis and aneurysm can also be something. And intracranial mycotic aneurysm, so that is also one. Prognosis, etc., complications, everything is written. It's very good, it's nice. Right, and the way I was asking you, so this is evaluation. And right, these are the etiologies which cause mycotic aneurysm. So this also you can keep in your mind. Good.
Yes, ma'am.
Then coming back to history taking, it was only 30 seconds, which you took extra. If I give you the feedback, your history was good. It covered everything, I think so. Anyone else want to
Yes.
give feedback? But when I asked you how would you classify aortic aneurysm, I was not completely happy with your answer. So I would want you to write down some lines on classification in all the possible ways you can classify, so that it may not come, but it will be helpful. Yes.
Sure, ma'am.
Good. Thank you. Starting timer, and here is the question. Right. If you have read and understood, let's begin the session. Can you please help me and identify number one, please?
No, this is arch of the azygos veins.
All right. Can you please tell me the tributaries of azygos vein?
Okay, there is formed from the ascending lumbar veins and right subcostal vein has
Okay.
accessory and hemazygous veins,
Yes.
and also there is the mediastinal and the bronchial.
Yes.
There is subcostal veins
Yes. Pericardial,
and pericardial veins.
esophageal, and bronchial veins as well. Did you mention right superior intercostal vein?
Yes,
All right. Can you please identify number three here?
this is the greatest splenic nerve.
Okay. What kind of nerve is this?
It is the parasympathetic nerve.
Okay. Where does it supply? Please tell me more about it.
It supplies the abdominal viscera.
Okay. Can you please identify structure, arrow pointing it here? Which structure is
This is
this?
sympathetic chain.
Yes. Can you tell me about it?
Okay, this is formed from T1 to L2
Yes.
and has connected to the spinal nerve, has sympathetic ganglion and white and gray ramus.
Yes. And
This has from T1 to T5 supplies the pre-sympathetic of the skin
okay.
and also supplies the abdominal viscera.
All right. Good. Can you please tell me how ascending lumbar veins are formed? or right costal vein? Tell me about it. All right, okay, we'll
I
come
don't
back
know.
to that later. All right, can you please identify all the structures from 1 to 10, 1 to 11 here? What are you looking at? Which view is
Okay,
it in?
one. This is the sagittal section of the thorax,
Okay,
only on the left side.
yes.
It's showing the mediastinum.
Mediastinum. What is mediastinum? Can you tell me the boundaries of the
It is
mediastinum?
cavity of the. It's a space of the thoracic cavity
Yes.
between the right and the left pleural sac. It has
Okay.
a superior and inferior mediastinum. The inferior is divided into the anterior and posterior and the middle.
Okay, anterior, middle, and posterior. All right. This is the right-sided sagittal view of the mediastinum. Okay. Can you please identify number 1 here, please?
This is
Trachea.
trachea.
Yes.
Okay.
And then number 2 over here, please. Please, coming here. 2.
This is the
Oesophagus.
groove for the esophagus.
It's oesophagus. Number 3, please.
Okay. This is the pulmonary artery.
It's the heart, it's cut, so it's left atrium. Number 4 here, please.
Okay. This is the ventricles.
Yes, it's ventricle. Number 5, please. Where is it? Number 5 is here. Yes.
This is the pulmonary trunk.
Aortic valve. And then number 6. Ascending aorta. See, valve and
The
then
arch
aorta.
of the aorta.
Ascending aorta. And number
Okay.
7. Right pulmonary artery.
The left. Okay.
And then 8. Number 8 is here. So there is something, and then here is 8. It should be easy. 8 is liver, right?
The liver.
Yes. What is 9?
Yes. The diaphragm.
Yes. And 10, please. 10 is here.
This is the sternum, the manubrium.
11. Body of
This
the
is the,
sternum. Okay.
the sternal.
Yes. Can you identify these small structures? Like this is A. What is this A?
This is the angle of the Lewis.
Can you name the structures which are located at the angle of Lewis? Why is
This is
it a
at T4.
landmark?
It has
Yes.
the arch of the aorta.
Okay.
And the superior vena cava, mainly the great vessels, the left common carotid artery, and the left recurrent laryngeal nerve, and the brachiocephalic
Can you
trunk.
tell me, please, the boundaries of superior thoracic inlet? Okay. Boundaries of superior thoracic inlet?
Means the superior mediastinum.
Or superior thoracic inlet? Or, okay, superior borders. Can you tell me the contents
the
of
same.
the mediastinum?
For the superior mediastinum, it contains mainly the great vessels, the arch of the aorta and brachiocephalic trunk, and the right and left phrenic nerve, and the right and left vagus nerve,
In
and the
which
left recurrent laryngeal
mediastinum?
nerve, and the internal carotid artery. The superior mediastinum
Okay, all right.
is bounded anteriorly by the manubrium, posteriorly from T1 to T4, and superiorly by the thoracic aperture and inverted imaginary line at T4.
All right, okay. Can you tell me the contents of posterior mediastinum?
The posterior mediastinum contains the esophagus and the thoracic duct and the sympathetic trunk and the esophagus, thoracic duct, and the sympathetic trunk, and also the AZYGOS veins.
All right, and thoracic duct as well.
And the vagus nerve.
And vagus as well. All right. Okay. And what about the anterior mediastinum? What are the contents of
Contains the lymph node and fat and the thymic remnant.
thymus remnant? Okay. All right. Can you please tell me? Right. Can you? Where is the question? Okay. Can you please identify the structures here from A to G? What this A is pointing at?
The intercostal artery.
Okay. We'll see. And then next.
B, this is the sympathetic trunk.
White is right intercostal vessels, right artery and vein. B is sympathetic chain, yes. And C, please.
This is the right phrenic nerves.
Right phrenic nerve, good. D, please.
The superior vena
Superior
cava.
vena cava, good. Yes, E.
This is the pulmonary veins.
Right principal bronchus.
Right principal bronchus. Okay.
Yes, and F. Right pulmonary vein.
The pulmonary veins.
Yes,
And this is the
because
precardial sac.
sorry, it's reflected upon to here. It's reflected out like this. So what is G?
The precardial sac.
Yes, over the right atrium, it says. So very good. Okay. Can you please tell me what is all right? How many embryonic pharyngeal arches there are, and which number arch disappears without giving rise to any specific structure?
There are 6 pharyngeal arches.
Yes.
The 5th ones disappears given nothing.
Okay. Right. From which embryonic pharyngeal arch develops thymus?
The 3rd pharyngeal arch.
Okay. All right. Good. Which pleura is sensitive to pain? Visceral or parietal?
The parietal. It is sensitive to
Pain, temperature,
pain
touch,
and
and pressure.
temperature.
Okay. What do you understand by the term thoracic outlet syndrome?
It is a neurovascular bundle compression between
Yes.
the scalenus anterior and scalenus medius,
Yes.
most likely due to cervical rib, which lead to neurovascular symptoms.
All right. Okay. How would you differentiate it from subclavian steal syndrome?
Subclavian syndrome, this is to create flow of blood downward from the vertebral artery.
Yes.
This will lead to dizziness and vertigo and loss of consciousness.
Yes. Good.
It is mainly due to steno-occlusive disease in the proximal of the subclavian artery.
Yes. Good. Thank you. Yes, starting the timer, and here is the question. Right. If you have read and understood, kindly begin your history taking.
Good afternoon. I am Dr. Jeta, one of the surgical doctors. May I please confirm your name, please?
I'm Sam. I'm 76 years old.
Okay, Sam. Would you mind if I ask you a few questions to test your memory today? Is that okay?
Yes, that will be fine.
Okay. So I'll be asking you a few questions. So if you can kindly answer them for me, that'll be nice. Thank you. So what's your age again, please?
I'm 76 years.
Okay. Your date of birth?
I was born in 1934,
Okay, that's good. Um,
5th June.
so okay, that's good. So can you please tell me the time to the nearest hour?
It's 2 a.m.
2 a.m. Okay, that's fine. So also I'm going to tell you an address. Then later on I'll ask you about it again. So can you get 42 West Street for me?
42
I'll
West
ask
Street.
you. Yes, please. Okay. So do you know the year we're in?
It's the year 2020.
2020. Thank you. Um, do you know my job description? Do you know who I am and then like what I do?
You are a doctor?
Okay, thank you. Um, do you know who's the current prime minister or the Queen of England?
Queen Elizabeth II.
Thank you. Okay. So can you count from backward from 20 to 1, please?
All right. 20, 19, 18, 17, 16, 15, 14, 13, 12, 11, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1, 0.
Okay. So can you remember the answer I gave you before?
42 West Street.
Okay, thank you. Okay, so do you have any other conditions, past medical history like diabetes, hypertension?
Actually, doctor, I have both diabetes and hypertension, and I also have what you call a rheumatoid arthritis, but
Okay,
my
are you
diabetes is controlled.
okay? You're on medication for all of them?
Yes, I do take medications for all of them, and I'm glad to say they're all under control.
Okay, so you didn't take more than what you're supposed to take today, or
Uh,
you took the normal dosage?
I can't remember. I think I took the normal doses. I think so.
I think so. Okay. Who do you live with, please?
My wife and my son.
Okay, that's good. So, do you know why you're in the hospital today?
I don't know actually. I can't remember.
Okay, thank you. Okay, thank you so much for answering my questions. Thank you.
Thank you, doctor.
Okay,
Thank you.
I should not ask.
Yeah, you can
Um,
ask maybe
sorry,
about
sorry, I
the
forgot. I
two.
forgot. I forgot. Do you have any idea of what's wrong with you?
I don't know,
I could.
doctor. I don't remember anything. Why I'm over here? What happened to me? Do you
Okay,
know
so
what has happened?
okay, and okay, you don't have any idea.
Hello,
Voice.
hello, Doctor Fatima.
You can ask what you expect from us.
Uh, if you could kindly please solve this problem. I don't know why I'm here. My sons brought me here.
Okay. Dr. Fatima, are you there?
I think so. It's just you and me, ma'am.
She got
I thought mine.
disconnected? Yeah, no.
Yeah, she did, ma'am.
All right, okay.
Oh yes, we can hear
Yes,
you.
yes,
I
yes.
lost connection. Yeah.
That's all right.
Yeah.
Can you
So
summarize, yes, the case for me now?
okay. So I presented a 76-year-old male that presented with that was supposed to have elective surgery
Yes,
um, today on account of inguinal hernia with a known history of diabetes, hypertension, and rheumatoid arthritis. Today presented with confusion and then was disoriented.
yes,
So on examination, on history taken, his um, abbreviated mental test scoring is more than 8.
yes.
Um,
So what is
it's
your
more than
differential diagnosis?
So my differential is the patient it's not actually having any dementia or delirium because his mental score is more than the normal. It's more than 6. So if it was less than 6, I would have said so. But I would have also want to do the mini mental state examination
Okay,
to continue my assessment. Yes.
all right. To rule out what?
To rule out any acute delirium or any other causes of the confusion.
Do you think patient is fit to go for the surgery?
Actually, it's not an emergency,
Yes.
but yes, so we could actually postpone and then investigate the patient.
Okay. So
Yeah.
how do you plan to manage the patient?
So I'll start by observing this patient during the bedside, the blood pressure, the oxygen saturation to look for signs of dehydration, and then all signs of infection in this patient. Then I will order for a brain CT scan to see, because it's a elderly patient, to see for any intracranial bleeding, hematomas also. But also I will do the bloods, full blood count to rule out any infection with WBC with differentials, to know the vitamin levels, the MCV levels, to know whether there is um, anemia, and then also to do the liver function test, the urea creatinine for the range electrolytes, and then also to do the INR for the clotting, the bleeding time. I also love to do the thyroid function test to know whether the patient has hypothyroidism, which could be a cause of it as well. A liver function test to
What
know
would
the
be the most important thing to consider in your management?
as in I also do a chest X-ray.
Anything else which should have more important impact?
Blood sugar, yes, the blood it's one of the
No.
bedside
Yes, these
issue.
all investigations you'll ask for, but then you'll also ask for the medical registrar to take over the patient or to
Yes,
give
I
you
will do that.
appropriate advice, because
I will do
if
yes, I will do that.
patient is not going for surgery, then it's not your patient.
It's not my patient, that's right.
Yes,
I'll also inform but I could also inform um the neurology registrar, right?
yes,
Okay. Hello.
yes. Good. Can anyone give feedback to Dr. Fatumata? You covered well within time, right? So I have no issue with time. Has she covered everything?
Just a quick question. I'm sure you covered everything. I'm just not
Yes.
sure if the patient has a less than 8 AMTS. Are we supposed
No,
to ask?
has more than, was
No,
supposed to
no,
act
no, not
confused, but
not related to your question. I'm just saying, like in general, if you have a patient
okay,
with
okay.
an AMTS of less than 8.
That patient should have two. Patient should be disoriented, and
Are
like
we supposed to take the rest of the history then?
you can't. You
We
will
can't.
be still.
We
You
don't
will.
have
You
to.
will still be trying, but you won't get anything out of it. You will give
Mhm.
the address to the patient to recall and repeat afterwards. Like the patient would not remember, patient would not even remember where the patient is. Patient will not recognize that
Yes.
patient is in the hospital. Patient will not even be able to tell you that you're a doctor and what your work
Yeah.
is. Yes, Dr. Ulfat?
I mean, other than those 10 AMTS questions, like you asked about the family history and all those things, are we supposed to ask family and past medical history and all those things then?
When you won't even go beyond those 10 questions, you
Don't
would
look at
never
that.
get the time to, yes, ask
Yes,
those
if the
questions.
patient is confused.
Yes.
Okay, fine.
So basically, what went wrong over here is the questioner did say that the patient was confused and disoriented. I'm so sorry, I
Confused.
overlooked it. I did not overlook
It's
it.
fine.
I saw it. Completely forgot
Oh,
to.
there he was telling you, act
No,
confused.
I was saying the correct answers, but
Yes.
actually,
Yes.
in this situation,
Actually,
Yes.
it is going to be disoriented, and the patient will be like, just like how ma'am said, won't be able to explain properly. So the score is going to come below 6,
Yes.
and at that time, yeah, it is going to come below 6. So the answers will follow accordingly. The questions will be accordingly. So
Uh-huh.
yeah.
So after your AMTS assessment, like you asked 10 questions, you
No,
know
you're
that,
going to only ask the AMTS, and you're going to
right? My
also
question,
tell the examiner that to complete this, I want to also do the mini mental state examination. But
Uh-huh.
and I did not ask further because she's already disoriented. You know, you could just
Confused.
mention that. That way, everyone's
Mine
clear.
was not confused.
fine.
Mhm.
Thank you.
And
Okay,
she
that's nice.
is saying that in the last exam, they were
Thank
asked
you.
MMSC.
yeah,
Uh,
examiner can ask you how you do MMSC, just
Yes.
gross idea. They can ask.
No,
Yes.
the last exam, I've got one of my friends. She went for London exam, so she did the AMTS, and after, when she had time left, he told her, "What are you going to do next?" She told him mini state examination. He told her, "Yes, do it."
Okay.
uh-uh.
Yes.
So
Okay.
you need to
To make
prepare. Yeah,
sure,
exactly. It was the surprise this time
yes.
because they want to perform it.
And to make sure the candidate knows what
Yeah,
Yes,
he
ma'am.
or she is
exactly.
talking about. So that's why I say gaining
Do
more
you say
knowledge
yeah? Uh-huh.
keeps you safe.
Yeah.
Good.
Hmm.
Thank you.
Yeah.
Here is the question. Right. If you have read and understood, kindly begin your examination.
Okay. Wash my hand. Hello, I am Mohammed Al Ayan, one of the exam candidate. After my confirm your name and age, please. Today I have been asked to examine your lump present in your groin that include look, feel, and then to the lump. Are you okay? Take
Yes.
the consent from the patient. Would you please take off your shirt and stand up for me? I will start by talking close look to your groin. Would you please cough for me? And then would you please lift up your scrotum and start the inspection, the swelling, and the comment for the site of the swelling, and then the size, and then the shape, and then the scar and surface and overlying the skin and visible impulse on cuff. And the inspection for the other side and external genitalia and the posterior scrotum, and the comment if any evidence of the evidence of the positive finding. And now I am going to feel the lump. I am asked the patient, do you have any pain at the moment? would you please cough for me? And then, do you have any pain at the moment? Could you reduce the lump? Now I will put your hand on your groin. You can relax your hand. By palpation, press on the lump and look the patient in the face to see if there any grimace, and then comment or use the dorsum of your of hand and compare the surrounding skin for the temperature, and then by superficial and deep palpation, use palmar surface of your finger to comment for the consistency, and then feel the edges with the radial border of your index, and then hold the skin between your thumb and index to see if the skin is adherent to the mass as a skin pinch test, and then feel the pulsation. Use tip of the index and the middle and ring finger as pulsatile the swelling or no, and test it as a fluctuation by place the index and thumb finger of the one hand on the swelling with index and the thumb of the finger of the other hand place in between of this two finger, and comment if any positive fluctuation or no, and then ask the patient to reduce the hernia himself while standing, then occlude the deep inguinal ring at the midpoint of inguinal ligament, and ask the patient to cough, and comment if reduce the swelling during the cough and the occlusion of the deep inguinal ring, and then palpate the inguinal lymph node and the medial surface of the thigh, and examination of the scrotal neck swelling, and palpate the mass separated from the testis or no, and then measure the size of the hernia by measure tab, and last ask the examiner to dim the light of the room and put the light source into the hernia and look through the cone to exclude hydrocele. And now I will listen to your lump, and then listen for any gurgling sound indicate of the presence of the bowel. And then thank you, sir, and you my dress now. Do you need any help?
Did you do deep inguinal ring test?
What's mom?
Did you do deep inguinal ring test?
Yeah, deep inguinal ring test. Ask the patient to reduce hernia himself while the standing, then occlude the deep inguinal ring and midpoint of inguinal ligament, and ask the patient to cough. If the could not reduce the hernia himself while the standing, ask the patient to lie down and then try again. If the patient cannot reduce the hernia himself or feel pain or refuse, do not try to reduce until the examiner that you could not complete the test.
Did you examine the both sides, the both inguinoscrotal regions of the patient, or just the affected one?
Yeah, examine bilaterally as
Both
inspection
sides.
and the palpation.
Yes. So can you tell me, can you present your case now? What was your finding?
Yeah, I examined this patient, a 62 years old male, presented to your surgical outdoor with swelling in the right inguinal scrotal region, progressive 6 months, has lost appetite and lost 4 pounds of the weight, and the swelling painless and do not reduce all at the all. My professional diagnosis could be inguinal hernia, and another differential diagnosis could be testicular tumor and varicocele and lymph node and the hydrocele and the spermatocord.
Okay.
And spermatocele.
Can you please tell me how would you differentiate, or what are the differentials that you'll keep in your mind for scrotal swelling?
What's mom?
What would be the differentials that you'll consider for scrotal swelling?
Yeah, the most common differential diagnosis as inguinal or femoral hernia and lymph node and varicocele, and swelling related to testis like hydrocele, lipoma of the cord, testicular tumor, and the epididymal cyst and orchitis, epididymitis, and the testicular torsion and spermatocele.
How should this be managed, this patient?
Yeah, the management after restaurant examination and the investigation and the management classified open and laparoscopic. Open as mesh repair, and the laparoscopic indicated in the recurrent or bilateral inguinal swelling.
Okay. Can you please tell me what are the types of repair? How would you differentiate Liechtenstein's repair from modified Bassini's herniorrhaphy? What is the difference?
Yeah, the modified Bassini herniorrhaphic. This is approximation of the congenital tendon and inguinal ligament by interrupted non-absorbable monofilament suture like Brulin. And the Liechtenstein repair once the hernial sac is removed and the defect closed and put the mesh and place it over the posterior wall and behind the spermatic cord and wrap around the spermatic cord at the deep inguinal ring and the loose sutured by the Brulin 20 put the mesh to the inguinal ligament and the congenital tendon to stitched by the 20 Brulin.
Good, thank you. One last question. Can you name few surgical options which are available for inguinal hernia?
Yeah, the surgical option could be herniatomy and could be open suture repair like Bassini Schuldeis and the Sarda, and open flat mesh repair like Liechtenstein, and open complex mesh repair as a hernial system and plug, and the open retroperitoneal repair like Stoba, and the laparoscopic like Tiba and Tab.
Very good, good, thank you. Yes?
Thank you, ma'am.
Anyone want to give feedback? Yes? We are discussing. Good. All right, thank you.
Thank you, ma'am.
All right, started the timer, and here is the question. Oops, I'm sorry. Right. If you have read and understood, kindly please tell me how many
Yes,
types of diabetes there are.
broadly classified into two. One is type 1 diabetes and type 2 diabetes. Type 1 is insulin dependent,
Yes.
basically arising due to a deficiency of production of insulin. There's an absolute deficiency of insulin secretion by the beta cells because of autoimmune destruction or whatever other causes. The incidence is approximately 10% of cases. More broader category is type 2 diabetes when there is a relative insulin deficiency, where there is adequate production, but the patient presents with a relative insulin resistance to the produced insulin. So the approximate category is around 80 to 90% of patients.
Okay. This patient has abscess and patient is diabetic. How would you define the term abscess, or how would you make me understand what is abscess?
Abscess is a collection of infected foci which contains. I'm not sure about the definition. I'm sorry.
Okay. Since patient is diabetic, what are the conditions that you'll consider before managing the patient?
So, in a patient who is diabetic, while preparing the patient for surgery, should be considered primarily as a first case in the list. Basically, there is a need for starvation, but there's no need for admitting the patient beforehand. The starvation time should be not more than one meal. There should be this should be mentioned in the WHO briefing surgical safety checklist that the patient is diabetic, and we should monitor the blood sugars. If the patient is fasting for more than one meal, then we should consider insulin infusions. Then the fluid of choice would be 0.45 percent sodium chloride with 5% glucose, with potassium KCl as replacement fluid, as
Yes.
IV fluid for management. We should also monitor capillary blood sugars every 1 hourly in order to avoid postoperative hypoglycemia. And the
Okay.
target blood glucose should be between 6 and 10 millimoles per liter.
Can you please tell me what is the pathogenesis of diabetes?
Depending upon the type, again, it's
Yes.
primarily if it's a type 1 diabetic, it's due to lack of insulin secretion. Could be because of destruction of the beta cells or autoimmune etiology causing lack of insulin secretion in the first place.
Yes.
The other is type 2 diabetes, in which there is a relative insulin resistance, where there is normal production of insulin, but because of obesity and other factors, the patient has a relative peripheral resistance to the produced insulin. And as
Okay.
such, there won't be adequate response of the
Can
insulin.
you please tell me what is the function of insulin at adipose tissues?
So in adipose tissues, basically it
Yes.
helps to mobilize the fat. It stimulates the lipid uptake into the cells. It enhances the oxidation of lipids and also causes fat deposition by stimulating lipogenesis in adipocytes and in the liver.
Okay, lipogenesis and lipolysis. All right. Can you please name few complications which can occur, or what are the which can occur as a result of not immediate or after immediate and
Yeah, with related to the
late.
complications, there can be immediate complications such as hypoglycemia. There could be dehydration and electrolyte imbalance, and secondary to that, because of inadequate fluid management. If there is a complications related to that, then the late complications that I'd be worried about would be delayed wound healing, infection. The probability of there's more chance of surgical site infection and pertinent sepsis after that.
Yes, and all right. Okay, can you please tell me the carbohydrate effects of insulin? How does it affect carbohydrates?
For carbohydrates, that is, insulin stimulates uptake of glucose into various tissues. It stimulates glycogenesis,
Yes,
especially in the liver, and yeah, those two. These one.
and
Increase
hepatic
uptake of
generation
glucose
of
into various tissues and
uptaken. All right.
increase
Okay.
uptake of glucose into various tissues and thereby decreasing the serum glucose level.
Who would you involve in the management of this patient?
I would definitely involve the endocrinologist if the patient is if blood sugars are not controlled properly, or the general physician, general medicine registrar for optimum control of his sugars.
Okay, just pause before you carry out your procedure. You realize that patient does not have controlled blood sugar level. What would you do?
We might have to postpone the case to get optimum control of his blood sugars and get an opinion from the endocrinologist registrar on call.
2, 4.
The
Because
endocrinologist.
maybe patient is already taking it's on oral medication, so you have to discuss it to convert it into insulin therapy maybe.
Insulin injections.
Yes,
So, okay,
yes.
yeah.
Okay, can you please
Okay.
tell me what are if there are any other hormones which are responsible for regulating blood glucose level other
There
than
could be
insulin?
fluctuation of glucose,
Yes,
fluctuation of glucose with other hormones such as glucagon.
yes,
Some glucocorticoids can cause a transient increase in blood sugar. Then catecholamines like epinephrine and norepinephrine can change this blood sugar values.
and
And somatotrophin.
proteins. Yes.
Yeah,
Okay, these glucocorticoids, it's more importantly affects on what?
it causes hyperglycemia.
Yeah,
Uh,
it's on cortisol. Okay,
Causes relative hyperglycemia.
yeah.
Cortisol, yeah.
Okay, can you also tell me that this patient, all right, right, has to undergo a local procedure?
Hmm.
Would you consider keeping this patient fasting, or when would you place this patient? on the list?
Depending upon the extent of the abscess, if it is the location is not mentioned, perianal
Perianal
abscess. So the
abscess.
perianal abscess. So then the patient will have to be done under general anesthesia. So I would put the patient fasting. I would preferably do it as a day case. Ask the patient to come fasting in the morning, and get it done early in the morning as a first case.
Okay. Can you tell me, since it's a diabetic patient, what are the organisms which are more likely to cause abscess in diabetic patients?
Usually, diabetic patients are more prone to developing skin abscesses secondary to skin infection like streptococcus or staph infections.
Yes, staph
But perianal
aureus
region
and
would be
staph.
more. It could be more would be E. coli or other organisms.
Okay. Can you also tell me why the patient with abscess experiences fever or has fever?
Um, because of relative systemic response towards the infection, which is localized, but still there will be localized inflammatory process.
Yes.
Cause the rise in inflammatory markers,
Yes.
and because of reaction with the hypothalamic set point, which increases because of byproducts of infection.
Yes.
Or I
Okay.
don't know if there's an answer.
Yes. Is there any other type of diabetes that you are aware of? Gestational.
Nephrogenic. Uh,
Gestational.
Gestational diabetes.
Yeah.
Gestational diabetes mellitus.
Yes. Good. Okay. Thank you so much.
Sorry,
Excellent.
the other one was yeah.
Excellent.
Okay.
Yes. And here is the question. Right. If you have read and understood, kindly begin your examination.
Okay. Okay, right. I'll enter the room.
Yes.
And wash my hands, greet the patient, and introduce myself. I am Dr. Nadeem, one of the surgical candidates, and I'm supposed to examine your right foot, in which I will look, feel, and do some special tests.
Yes.
So if you have any pen, just tell me in time. And even during the examination, you can stop me at any time if you feel uncomfortable. Is that right with you?
Yes. There'll be no
Okay,
patient,
after
so
that,
you'll explain. Yes.
I'll ask for pain control. If there is severe pain, then I can offer a painkiller at that time. And after that, I'll tell the patient to have exposure up till the knee joint. And I will, after that, in standing position, I'll look from front, side, and back of the ankle joint to see for any swelling, scar marks, any veins, sinus discharges, or any pulsatile masses, or any deformity of the joints, and any change of skin color. After that, I'll tell the patient to move if possible, to walk normally, and also walk on toes and heels if possible for him, otherwise not. After that, I'll tell the patient to sit on a couch, and I'll tell him to do active movements of dorsiflexion, plantar flexion if possible for him, otherwise not. And also do eversion and inversion actively.
Okay. Yes. And yes. Any other investigation examination you'll carry out?
And yes, after that I'll passively move all the joints of the phalanges and the mid-tarsal and tarsal joints, and also look for any tenderness looking at the face of the patient while doing all these examinations. After that, I will also palpate the dorsalis pedis and artery, and after that I'll ask for a Simon test, in which, if possible for the patient, I'll make him place himself prone on the couch and press the calf muscles. So if there is plantar flexion, the Achilles tendon will be intact. After that, I will do some special tests for Taylor tilt test, and in which I'll do it in dorsiflex. I will do it in neutral position and trying to invert the foot of the patient. So if it is laxed, then there will be tear or deformity of the lateral talofibular joint. Sorry, ligament.
Ligament.
And
yes.
Ligament, yes. And if there is anterior, I will also put with the left hand the leg, and with the right hand I'll apply pressure anteriorly in dorsiflexion for the anterior talofibular ligament and in plantar flexion for the posterior talofibular ligament. Sorry, for the anterior talofibular ligament. So if there is any laxity, then it will show the tear of the anterior or posterior talofibular ligaments.
Good.
And
With
after
anterior
that,
jaw test. Okay. If it is
and after
positive,
that,
then how
if it
would
is
the
positive,
patient
then
test?
there will be. So if it is going forward, it will be posterior. If it is going easily posterior, then it will be anterior ligament here.
Okay, good.
And after that, I'll thank the patient, tell the patient, wash my hands again, and will ask the examiner for completing about
Okay, can you present your case now?
And complete exam. I have examined this patient who came after trauma and had pain in his right ankle. Now, if the patient has asked for anything, I offered the painkillers, and after that, I observed no apparent swelling, deformity, or color change in the ankle region, and the active and passive movements were normal apart from tenderness or pain while doing this. And the Simon test was normal, and the anterior and posterior talofibular ligament test and the lateral test, they were negative.
Okay.
So based on
If
this
there is
examination, my
sprain,
bag.
What should your taller test, taller tilt test finding be?
Then there will be only tenderness,
Yes.
but no laxity of the movement.
Okay.
And so differential will be ankle sprain, ligament tear,
Yes. Yes.
or syndesmotic fractures,
Yes.
or
base of the
talar
fifth
fracture, peritoneal
metatarsal.
fractures,
Yes.
and metatarsal fractures,
Yes.
or
Okay.
dislocateal fracture alone, or fibular fracture alone.
Yes. So how would you manage this patient? What investigations would you ask for?
Okay, following the ABCD protocol and stabilizing the patient initially, I'll go for complete history and examination as well, and we'll do one joint above and complete examination. After that, I'll apply splint, follow painkillers management, rest, elevation, compression of the ankle joint, and then also doing X-ray, epilateral view of the ankle joint, and if needed, for diagnosis, MRI of the ankle joint. And baseline investigation including CBC, CRP, ESR, and uric acid, and calcium levels, along with vitamin D levels, and DEXA scan if needed, to rule out osteoporosis if it warrants so.
If you have done
and after that,
X-ray of the foot.
After that,
yes.
After okay.
Yes, please.
Okay, what
continue.
are the findings?
I'm sorry. Continue, please.
Okay, so if there is any fracture, then we'll refer the patient to orthopedic surgeon, and it will be managed accordingly, depending
If
upon
you
the
have done
urgency of the.
X-ray and there is undisplaced fracture fibula with just only swelling of the ankle, what should your management be?
So best ice and compression, limb elevation with splinting and caster,
Yes,
plaster of Paris cast,
yes.
and rest,
Backslab,
rest for
non-weight
4 to
bearing.
6 weeks.
Yeah, rest, analgesia, and yeah, elevation to reduce edema. Good, very good, excellent. Yes. Okay,
Thank you, madam.
good, excellent.
So, madam,
Yes, again,
you can give me any station daily. You can throw anybody.
anything. But
Yes.
what I okay, starting the timer. Kindly read your question in 1 minute. Right. So, oops, if you have read and understood, can you please help me and identify the marked structure starting from the left-hand side? Which bone is this that you're looking at?
This is the femur.
Yes. Of which side? Can
Should
you
I say left
identify?
or right? Yeah.
Yes, as much as you know, please.
I guess it's I feel at it's the right side.
Okay, then can you please identify the structures? Moving here on the left side, picture
Okay.
A.
So the 3
Can you,
is the head.
yes, can you identify number 3?
Yeah, it's the head of the femur.
Okay.
And
And
number
then 6,
yeah.
number 6 here, where is it? Yes.
What is
Here.
it? Okay, it's the surgical neck.
Yes, what is the importance of surgical neck of the femur?
So the importance is that if there is any fracture here, it will be osteonecrosis because of the compromise of the vascularization.
How do you classify the neck of the femur fractures?
So there is a Gardner classification.
Good. Grade wise, tell me please.
Oh dear.
Okay,
Forgot
we'll
about it.
come back to it later.
Yeah.
Okay, number 2, here, can you identify what that is?
It's the gluteal trochanter.
Okay, and number 4 here?
Number 4 is the intertrochanteric, I think, groove or.
What is the importance of it? What are attached here? Yes. All right. We'll come back.
I mean, I think if I'm not wrong, so
In
there
exam
is
you'll not
the
say I
line
think.
here.
Yes.
It will insertion of quadratus femoris.
Okay, we'll get back to it. Can you identify number 5 here?
It's the lesser trochanter.
Okay. What is 9?
Is the shaft of the femur? Or not?
Good. Have we identified? Okay, we have identified 6. Can you identify 11 here?
I don't know.
Trochanteric fossa.
Yeah. Okay.
What is 5?
5 it's the lesser trochanter.
Okay. And what is 3?
I don't know.
Head.
Is it the capsule?
3.
3. Yeah, the head. Yeah.
Okay.
Yeah.
Can you see number 1 here?
Is I think it's the fovea, and there is insertion of ligament tears, I think.
Fovea of head, okay. Can you tell me why there is this punctum or this?
There
What's
is
the
a
importance of it?
vessel which is piercing here, isn't it? Or
Which vessel? Yes. What's the name of the vessel? What's the importance of that vessel in children?
they call it artery of ligamentum teres, or I think it's a
Okay,
branch
what's
of
the importance of that vessel in children?
I don't have
All
answer.
right, we'll come back to that. Okay, number 4 here, please. Can you identify?
What the number 4? I said like it's femoral lion, which I don't know. I said that the insertion of the muscle quadratus femoris when it's
No, it's head.
inserted.
Okay,
No.
4 is the head of the femur, right?
Where?
Here
4.
in this picture on the right hand side. Now I'm
I
discussing
didn't see
picture.
this. No, that sorry. Sorry,
Picture
it's my
A
bad.
on the right hand side, number 4, head of
Yeah.
the femur.
This number 4 is the
11.
head. Yeah.
Yes, can you identify
Is the
number
neck.
11, please? Okay,
It's the neck.
Yes, here number 3, please.
Greater trochanter.
Okay, number 12, please.
Number 12.
Okay, number 5, please. You can help all people listening. Tell Dr. Lilia what number 12 is. Okay, number 5, please.
Yeah. I mean, this is that I forgot them. There is 2. Yeah, I forgot it. This one I forgot.
We'll come back to it. Number 8.
We come back.
Number 8, please.
So the lesser trochanter.
Okay, good. Number 2, please.
Number 2, there is it's a shaft, but there is what do we call it?
It's not shaft, okay?
No. It's
all right. Number 9, please.
This is the shaft, isn't it?
Yes.
Or not? Yeah, this is
Linea
the shaft.
aspera, okay.
Linea aspera, yeah.
What is 11? Number 11 here. For in
is
C,
it
picture C.
Yeah. Is it not trochanteric?
It's the view from above, so it's neck. Okay, number 8 over here.
It's a tuberosity, number 8, isn't it?
Okay, number 4 again.
It's the head.
Good. Okay, number 4 again in B
is
picture.
The head.
11.
Yeah. Is the neck.
Okay, what is this? 6.
Is it the one that getting linea aspera is getting up?
It's number 6, intertrochanteric line.
Yeah. This is
okay, number 3. Number 3
is the greater trochanter.
Okay, can you tell me how the hip joint is formed?
So the hip joint is formed between the head of the femur and which will articulate with the iliac bone with the glenoid cavity.
What kind of joint is hip joint?
A synovial joint. Bone and socket, I think.
Okay. Can you tell me the blood supply of the head of the femur in adults, please?
So the blood supply of the head is from retinacular artery, which are the branches coming from extracapsular arterial anastomosis and form between femoral circumflex arteries. And as well, it's there is less. There is the fovea is coming from ligamentum teres.
Okay, can you please
so there is
tell? Yes.
Yeah, as I said, there is the main blood supply is from the arteries which anastomose from the posterior anterior femoral circumflex arteries, and the part of the fovea is from the artery of ligamentum teres, which is from a branch of obturator artery.
Okay, can you please identify all these muscles? What are you looking at from the back?
I'm looking on this is the sacrum.
Yes. So can you identify
and this
all
is
these?
Iliac bone.
Okay, this is iliac bone. Which muscle is this?
This is the, I think this is the gluteus maximus.
Can you continue and tell me all which one? Okay, which one is this? Sacrum. Which muscle is this?
I mean, like, this is the gluteus maximus. The one is medius. This is the one on the top is the gluteal maximus. And
Then,
the up, the one is medius. We cannot see minimus here.
okay. What is this pointing at?
Is it coming from the glut? Where is it? Is it part of the sacrum here?
I'm
Yeah.
asking.
I don't
Okay,
know.
can you tell me what are the muscles which attaches on the ischial tuberosity?
Yeah, the muscle attached to the ischial tuberosity. So I can see that on the top there is quadratus femoris muscle. It's attached from the ischial tuberosity to the quadrate line on the femur. And so there is
How
obturator
would
as
you
well.
test? What is the test name with which you can detect the weakness of gluteus medius muscle? Medius?
Okay, so yeah, the test is called the Trendelenburg test.
How do you do
And
it?
how we do it? So we ask the patient is standing. We are supporting the patient from the hips, and we ask the patient to stand up on one leg and lift the other leg up. And if there is weakness, the patient the pelvis will drop toward the contralateral side.
There'll be weakness, so patient will be okay. Good side sags. All right. Okay. All right. Can you please identify or tell me what are you looking at?
Okay.
What
This
is
is
this?
I think it is the angiogram of
Femoral arteriogram.
yeah, femoral artery.
Can
Yeah.
you identify all the structures from 1 to 7, please?
Okay. So, I mean,
what is this one? One is catheter. Okay, I'm telling you, they are introducing into distal abdominal aorta through the right common femoral artery. Now, please tell me and identify number 2.
Is it the femoral artery, isn't it?
Yes, common femoral artery.
Yeah, common femoral artery.
Number 3, please.
Number 3, where is it? Is I think yeah.
Circumflex femoral artery.
Yeah, which is like number 6. It should be like the deep profunda.
Yes, profunda femoris. Yes.
And yeah.
And number 4, please.
On anterior tibial artery.
No, this is
no.
lateral,
Number
so
7
this
is
is
anterior.
Number 4 is
anterior
medial.
is 7. Yeah.
7 is superficial femoral artery.
Superficial femoral, yeah.
And number 5? Perforating branch.
Yeah.
Okay. More. This is the last one. Can you identify all these vessels?
Okay,
which one is which?
Okay, we are still in the femoral here.
We are still in the lower limb, yes.
I mean, yeah, it's a femoral. It's not down like popliteal. It's so we say like I can't see the numbers. The first one, the branch is
this one is
it's common femoral.
It's popliteal.
Are we down? It looks for me it's like the thigh. That's why I said.
Yes, and number 2.
So then, if it is the popliteal, then the popliteal, then the branch on the right side, it will be anterior tibial artery.
Yes.
And then one with the 2 branch.
This
the
one
lateral
is
one.
anterior tibial. And then which one is this? Peroneal.
This one is peroneal. Yeah, and the other one is
yes, which one is this?
this is posterior tibial.
Yes, and one that you have missed is tibioperoneal trunk.
Yeah, the trunk, yeah, tibioperoneal, yeah.
Right?
Because it will give peroneal and posterior tibial artery.
Good, thank you. It was your first time, and I'm sure you know that you need to go back and read.
Yeah, yeah, I will
Read
definitely.
more carefully. Yes, the lower limb. Good, thank you.